Hi, everybody. My name is Anna Lee Cawthorn with the Tennessee Commission on Aging and Disability. We serve as your state unit on aging, and we also provide administrative support to the State Palliative Care and Quality of Life Advisory Council. I'm very excited to introduce our speaker for today's webinar, Dr. Greg Phelps. He's the Chief Medical Officer for Aleo Health, and he also serves as Vice Chair of the State Palliative Care and Quality of Life Advisory Council. Very excited to have Dr. Phelps with us today. And Dr. Phelps, if you want to share your slides.
Thank you. Let me hit the share button. And there we go. So good afternoon. I'm Greg Phelps, and as introduced, I'm the Chief Medical Officer for Aleo Health. I also wrote a book about going back to school to learn about hospice called Education of a Hospice Doctor. And I am delighted to have the opportunity to spend some time talking about advanced care planning. There we go. So first of all, I want to talk a little bit about communication. And communication is one of the 6 core physician competencies according to the Accreditation Council of Graduate Medical Education. The others are medical knowledge, practice-based learning, interpersonal and communication skills, professionalism, and systems-based learning. The problem is so often that we don't do a great job as physicians and providers in communicating. A 2015 article in the New York Times was labeled, "Doctor, Shut Up and Listen." And it notes the average physician interrupts the patient within 18 seconds of the encounter, and that only a quarter of physicians in the hospital actually introduce themselves. And communication is so vital with patients and we do such a terrible job at sometimes. Joint Commission notes that 70% of the serious errors that are involved in sentinel events are related just to communication. And particularly when we get to a very difficult topic or squeamish topic like advanced care planning, end of life, goals of care, we really fall down on the job. We are a death-denying culture here in the United States. They say in Asia that frequently they look on death as necessary for the next generation to be able to come up. In Europe, they look on death as inevitable, and too often in the United States, we look on death as optional. I like to tell my students that all of our death certificates have an invisible expiration date. It's just purely a matter of getting to it. So when do we talk about advanced care planning and goals of care? And the ideal time, and I say this as a family physician, is in the primary care physician's office when nobody is sick, nobody is ill, and we're all doing okay. We talk about 3 levels of conversation, and it's really your life, it's your choice, it's how you choose to live your life. So the first time is when you're young and healthy, express your wishes, how you would want to see your life in its final phases. Then again, after 55, maybe encountering some serious illness, and then again encountering a life-ending or life-threatening illness and reviewing your choices. Because I can promise you that my choices at age 28 are very different than my choices now at age 67. And so it's not a one and done, it's something that has to be come back and reviewed. And it's not the paper, as we'll discuss later, it's the conversation with your family so you'll know what people want. But the challenge is having the conversation, and I am married to a nurse, and I have tried to have the conversation. She knows what I want, but for me to have the conversation about what she would want has been ongoingly difficult. And in fact, she had a heart attack a few years ago and ended up with quintuple bypass surgery. I gave her a couple days to recover, and then I said, okay, now we're going to talk about what if this had gone badly. And she said, I don't want to talk about it. And I said, well, let me tell you what I'm going to do, and you can disagree with me if you wish. And so I told her what I would recommend for her, and she said, sounds good. And that was our goals of care discussion, even between a doctor and a nurse. So there are a number of barriers that we see frequently with the, hang on a second, I'm trying to stop sharing here. There we go. Having this conversation. I'm in debt to Rosemary Crawford George, who taped a conversation about advanced care planning. And these are some of the barriers she came up with and some more that I have added to it. First of all is deficits in patient and caregiver understanding and illness. It is important to know that 36% of the U.S. population is medically illiterate. In more economically depressed areas, that goes up. And in fact, in my home city of Detroit, it's 50%. Keep in mind that only 50% of the U.S. population can actually name the 3 branches of government, according to a recent survey. So a lot of it has to do with education. Also, you've got multiple providers with varying options. I like to say every part has a doctor and every doctor has a part. And having been a former medical director for a hospital, I can tell you if you have 8 doctors, you've got 88 different opinions as to how things are going. Another problem is medical jargon. I had a patient one time I was talking with, and I said, "Did they tell you what your dad has?" And they said, "Well, they say he's got a neoplasm in his thorax, but thank God he doesn't have lung cancer." And I was a little earlier on in my career, and I said, "But that is lung cancer." And they just lost it because that was the one thing they really, really feared. The pressure in making decisions in the face of conflicting or imprecise data. As I say many times, I'm not God, but this is what I think, but oftentimes we don't have enough information. There's also the good old American do everything spirit. And I've had patients that have come in with they're on dialysis, they're on a heart assist device, they're on a ventilator. And one family said, well, the one thing we want you to do everything, but he'd never want to be on life support. And I kind of stopped and said, but he's on 3 kinds of life support. And they said, oh, he wouldn't want that. We don't really discuss the benefits versus the burdens of what we're doing. Sometimes we're not doing things for patients, we're doing things to patients, and that can be a barrier because frequently the families don't understand the pain and suffering that goes along with the things that we do. Another common barrier is the idea that if we make the patient allow natural death or DNR, that we will stop caring for them. The ever popular no code means no care. And we have to say, we will do everything except CPR on your loved one. And talking about CPR, the popular media misconceptions around end-of-life care, particularly around CPR. There was a New England Journal study a decade or so ago that talked about people watching, a physician watching television and finding that the success rate for CPR on TV was between 65 and 100%. And so I said that if you ever went down, Rescue 911 was where you wanted to be because they never lost anybody. So the patients and their families see this on TV and they assume that's what really happens. Also, another barrier to having this conversation is the emotional urgency and intensity of the families and oh my God, dad's in ICU. Is he going to live? Is he going to die? Makes it very hard to absorb information. They say that patients, even the doctor's office, retain less than 50% of what you've said. If you're standing outside an ICU and you're trying to have this conversation, it's a whole lot worse. There is also family dysfunction and estrangement. We talk about the dreaded child from California, the one that hasn't talked to his sister or his dad in 20 years, and now his sister calls and says they're going to take dad off of life support tomorrow. He hops the red eye and comes back and makes everybody's life miserable, and I have been through that a couple of times. I did ask someone in California, what do you call it? And they said, oh, it's the dreaded child from back east. There are also frequently time pressures and urgency. I need a decision now, what we're going to do. And of course, COVID and isolation has made all this worse. Working with my nurse practitioners and physician's assistants, what we so often see is mom went into the emergency room for a sore throat, and now she's intubated, she's on a ventilator, and the family has no concept of how badly she's gone downhill. And then palliative care comes to say, we need to have a goals of care discussion. And they're like, what are you talking about? How can we've gone from a sore throat to talking about what we're going to do to try to keep her alive? And lastly, there's the fact that people don't absorb negative information as well. There was actually a study that was done. They looked at patients in the ICU and they gave them good news, said 95% chance your loved one's going to get out of the ICU. What did I just say? They said, you said good news, the 95% chance they're going to get out of the ICU. Then they did another set of patients and they said, things are really looking bad, less than a 5% chance your loved one's going to survive. What did I just say? And the lowest estimate was, you said there was a 25% chance that my loved one could die. People don't absorb the information when it's bad as well as they do when it's good. So keep in mind, that's the hill we're working up to have a goals of care discussion. So I'm going to go back to sharing here. There we go. Well, if I can get it. I'm not sure which slide I'm sharing right now. Let's try clicking on this one. Okay, so the family conversation, this is how you can open a conversation. And I like this one. It was told to me by my friend, Dr. Brian Johnson. He calls it spam, and it's a way to just kind of throw open the door, if you will. The S is for surrogate, or who speaks for you. That one's usually pretty easy to say. And if they have a question, I'll make it very immediate by saying, you know, we're sitting here at this conference table, you stand up and trip over the chair and fall down and hit your head on the table and you're unconscious. Who do you talk to? And they'll usually, oh, it's my wife. The next is, do you have any preferences about your care right now? It's astonishing how many 80 and 90, 75-year-olds say, for God's sakes, don't put me on any machines, or just my time comes, let me go. So they've got an existing preference. Then A is, I'll assume you want everything for right now. And then the M is, we'll talk more about this. This is a relatively pain-free way to open the conversation and be able to start it. That way, when you come back and say, we need to talk more about this, it's not as big a shock. Let's see. Then if we press on a little bit further, we can talk about spikes. And this comes from a Dr. Bales, and it talks a little more about goals of care. First is setting. Make an appointment, find a conference room. This is important conversation. We don't just photobomb the patients by walking up and saying, well, things don't look so good. It was a fairly famous case of a doctor who called his patient and said, your scans came back, your cancer is worse, there's nothing we can do, good luck, you don't need to come back. That person's estate donated money to the doctor's medical school to start a institute for physician-patient interactions because of how upset the patient was at that conversation. Next is perceptions. What do you perceive about how the patient is doing or how you're doing? What do you know about what you've got? The I is, can I share information about the diagnosis and likely outcomes? And then the K is going back to elicit understanding. And we talk a lot about the ask, tell, ask version of sharing information. What do you know? Let me tell you something. What did I say? The E is to validate the emotions. I've been threatened with physical violence. I've been threatened with lawsuits. I just have to stay calm and say, I understand you're very upset. I can see you're angry. I can see things are not turning out the way you were hoping for, but we need to move forward and make some decisions as to where we go from here. And then the last is summarize and then document. That's a good place to put who was at the meeting, what was discussed, and what the outcomes were, because inevitably your partner will be on and they'll be in, you know, and the dreaded child from California will show up and you'll have to start all over again. Let's see here. So this is the whole goals of care discussion. You'll notice each one gets a little bigger. And this is pre-planning and semiotics is the study of meaning. So sitting down, silencing your beeper, silencing your phone, which I had done, but turned it back on, and being prepared, knowing what the patient is about, talking about the family. Introductions. Remember, I said that less than a quarter of physicians introduce themselves. So I tell the patient and or their family, we're going to have a goals of care discussion. I've set aside the fourth main conference room. Bring whoever needs to be there to have a conversation about where we're going. And we go around the room introducing ourselves, the doctor, the nurse caring for the patient, the other specialists if they're willing to come, and then also prepare the people on the professional side so they know what's going to happen. I had one disastrous case where the surgeon came in at the last minute for the goals of care discussion, looked at the family and said, I don't understand why we have to have this meeting. Your mother's dying. This doctor pointing at me is going to take care of her, and good luck, and walked out. So we talk about the purpose. We're here to talk about you or your loved one and kind of where are we and where are we going? Tell me about the patient. Now, the classic thing is the family will say, well, he's got lung cancer. So tell me about him as a person. Paint me a picture of what his life is like. What is he like? What is he not like? How do you interact with him? There's an important point that says the family and the patient will not care how much you know until they know how much you care. You have got to deal with the emotions and the empathy in these kinds of conversations. Then what do you understand about the diagnosis? I had one family that said, well, they say he's got adenocarcinoma of the pancreatic head. And I said, and what does that mean to you? And they said, I don't know, but I learned to pronounce it. So then I had to say, well, let's unpack that a little bit. And I like to start with a warning shot, which I call I wish statements. I wish I didn't have to have this conversation. I wish we didn't have to be here. I wish things had turned out better. The subtext here is, I'm about to ruin your day, pay attention. The next thing is to explain the diagnosis, avoid jargon. Do not say adenocarcinoma of the pancreatic head, because anything more than 2 syllables is likely to go right by. If they have cancer, say cancer, and then describe where it is in lay terms. And the plainer, the better. I had one patient give me what I thought was the ultimate compliment. They said, we like talking to you, Dr. Phelps. You talk plain as dirt. And I took that well. So, and then the hard part, because we've said something that's agonizing for everybody, but we have to shut up. We have to await the reaction, see what they have to say, validate their emotions. I've had people kick over tables. I've had people get upset. The best thing to do preparing for this is to practice with somebody. In my book, I talk about where we had to practice. We had the hospital medical director, and I had to tell him he had pancreatic cancer. It was a setup. We were both given a sheet of paper. His said, or mine said, tell him he has, pancreatic mass measuring so many centimeters by so many centimeters, likely adenocarcinoma of the pancreas. And his slip, as best as I can guess, said, go for the Oscar. Because I sat down and he said, well, I'm just waiting for my scan. And I said, well, Mark, I wish I had better news. He said, oh, well, I'm feeling better, but what? And I said, well, it looks like you've got, I looked down at the paper and I read it. And he said, oh my God, cancer, and stood up, kicked over the chair. It felt real. You got to practice it. I had another time in my fellowship where one of the faculty said they wanted to deliver the news and then started crying while they were doing it. So it's a skill. That's what I spent a year in a hospice and palliative care fellowship doing, is learning how to deliver bad news and to look for goals of care. So await the reaction, validate their emotions, keep the focus on the patient. The families, I've been threatened with several lawsuits, and I say, yeah, I understand. You can sue me later, but right now, today, I need to know what your dad would want. Did he ever talk about advanced directives or code status or anything like that? And remember that we're looking for substituted judgment. So we want to be able to prepare them for what would the patient want. Sometimes I've even said, they're pounding the table saying, I want this for my dad. And I said, I understand you want your dad to live forever, but what would he say if he could get up, come in here and lean over your shoulder about how he's feeling about this? And then we'll talk about what I like to call allow natural death, or DNAR, which is do not attempt resuscitation, and CPR, and then summarize and record. A key point here is that the goals of care discussion success is based much more on what the family and the patient talk about than what you talk about. Other things are happening, asking open-ended questions. Now, as a family doctor in residency 40 years ago, I was schooled in how to steer the conversation to get through it as quickly and expeditiously as possible. And I can guarantee you that open-ended questions is a way to make this conversation go on for a while. But that is how you get the family to understand where they are. The next thing is we can't completely abdicate our responsibility. The patient is the expert on the patient, but we are an expert on the illness and the prognosis and the diagnosis. And so you can't just say, well, here's the information, do with it as you wish. The conversation has to be around some recommendations. Now, again, I say, is it okay if I talk about this? The astonishing thing is how many patients want to know prognosis, how many families want to know prognosis. Just last week, I was in talking with a patient who had COVID and was doing very, very badly. And the wife said, apropos of nothing I'd said, why will nobody tell me what's going on, and why will nobody tell me what the likely outcome is? And I said, I'll do that. I'm not God, but I'll tell you. And I did. And most patients and families want to know. And it's an educated guess. I always tell them that. But it's important for them to get a feel for, are we talking hours, days, weeks, months, years? I had a gentleman a number of years ago said, nobody ever asked me, how it feels to be dying. And I said, okay, I'll bite. And he said, it feels good. And I said, excuse me? And he said, I've served my family. I've served my country. I'm comfortable. My family's here. Dying is not the worst thing that can happen to me. And so it is so important that we understand kind of where the patients are coming from. I had one patient, I told him, I'm really, really sorry. I think you've only got a few months. And he said, oh, thank God. I was like, what? And he said, I thought the way you guys were talking, I was going to go today or tomorrow. He said, my life just opened up. So you never quite know what people are thinking. It's always helpful to ask, what do you hope for? What do you fear? What do you want? But we also have the obligation to tell them, I don't see this going well. I had one family, they were the family of a very elderly farmer. He was getting dialyzed. He was on a ventilator. He had dementia. And I said, what are you hoping for here? And they said, we're hoping he gets well and goes home. And I said, and does what? And they said, oh, well, he was a farmer. And I said, so you're thinking he'll be out in the fields and the sunlight coming down and the birds are chirping and this? Yeah. And I said, I don't want to be the bearer of this bad news, but the best you're going to probably get is you can roll his bed to the window and he can look out, and I'm not sure he's going to know what he's looking at. And the family said, oh, well, he wouldn't want that. And I said, that's why we need to have this conversation. So the next thing I want to talk a little bit about is Tennessee Healthcare Decisions Act 2004. And it allows us to establish a surrogate. If there's not a written living will or advanced care plan, as I'll discuss in a moment, the physician can designate a surrogate. The surrogate should be someone who knows the patient. It should be someone who's willing to make hard decisions. It should be someone who's available and able to have that conversation and do substituted judgment. It also allows for advanced care planning that doesn't require a lawyer or a notary. Two people can witness the patient's advanced care plan. The advanced care plan, what we used to call a living will, can overlap some with what they call the physician's order scope of treatment, or post form. And a post form allows designation of code status along with who you would want to speak for you. But the advanced care plan is more like, if I get sick and can't speak, this is what I want. So there is some overlap. You can get the advanced care planning forms from the state website, honoringchoicestn.org. I'm sure you can also get them at the aging website. And you can also use commercially prepared products such as 5 Wishes. So then you can also bill for these services. I would be remiss if I didn't mention that. There are 2 CPT planning codes for this. The first one, if you talk 16 of this 30 minutes, then you can bill for that. And if you go an additional 30 minutes, which would be 46 minutes, you can bill additional time. And I'll be honest and say a goals of care discussion can go close to an hour when you're meeting with the family. You'll notice here it says requires face-to-face. I believe that's been set aside for telehealth, but I'm not positive. But the patient does not have to be present. And what do you have to do to document it? Time in, time out. Person designated to make decisions, what was discussed, who discussed it, and what documentation was or was not done. You can have, I don't encourage this because not only anybody go to jail, but you can have a conversation about advanced care planning every day if it's moving the conversation along, and be able to bill for it as long as you spend that minimum of 16 minutes. So what we've talked about is the challenge for doing goals of care discussions, the barriers to doing goals of care discussions, how to have a goals of care discussion, how to talk about end of life, and finally how to bill for it. And with that, I'm going to stop. I thank you for your time and attention, and continue learning about advanced care planning and hospice and palliative care. Thank you.